Good evening. Tonight I wanted to speak about an experience I had in my more formative years near the end of medical school. I realize this doesn't quite stay in line with the framework I originally set up for these vlogs, namely recounting notable things that happened to me while on duty in the emergency room in an urban hospital. But I'd hate to get too beholden to staying within such narrow margins. I thought about this video being the inaugural entry in a new series, the Medical School Chronicles, or something like that. But after careful consideration, it seemed that way madness lay. Things would end up just fragmenting further and further into more and more granular subdivisions. The Private Practice Chronicles, the Residency Chronicles, the year I didn't practice medicine at all except in my garage Chronicles. It would just keep going. So for now, I'm going to keep them all lumped into the ER Chronicles. Ironically, that name may come to have a dual meaning, but I don't want to speak about that just yet. So I'm just going to do this for my own sanity as much as anything. I have had some people request that I exaggerate the binaural aspect of these videos. I do have my mics set up to capture binaural sound, but it's pretty subtle. It's just if I happen to turn my head one way more than the other, you get a little bit of that binaural effect. Really, it's just stereo, right? So, I'm going to try and emphasize that a bit this time out, see how it works. I may just abandon the idea halfway through. We'll see. But anyway, back to the story. As I mentioned, this happened to me during my last year of medical school, and it was one of those experiences that stays with you and shapes what you want out of life and ultimately what sort of doctor or person you will become. It may or may not resonate with you as deeply as it did with me, but for me it was quite affecting to the point where I find myself thinking about it in my day-to-day practice regularly. And what it was primarily was a connection made for me between what I had thought up to that point were two fairly disparate, although connected emotions, fear and anger. After I had this experience, I came to believe that specifically anger cannot exist without fear. So many years ago, while I was doing rotations during my 4th year of medical school at the University of Florida, go Gators, I chose psychiatry as one of my elective rotations. The way rotations work, in case you're unaware, at least the way they worked back in the late 90s, was that you had to complete a set of core rotations, and those were things like general surgery, cardiology, internal medicine, sort of the basics. You worked in a clinical setting for each specialty for a few weeks. I think it was 3 or 4, and then you'd move on to your next subject. This would continue for 2 years straight, your 3rd and 4th year of medical school, typically. So the intent of this exercise is to direct you to the specialty you're most comfortable with, or the one you get the most personal satisfaction out of, or maybe just what you find you happen to be best at. From there, you move on to your internship, your residency, and finally, you're set out into the world to make your own terrible, irredeemable mistakes and live with the often grave, soul-crushing consequences. So as I mentioned, one of the elective rotations I chose was psychiatry. As I've stated in a previous vlog, I don't find myself compelled to study psychiatry generally. I'm not particularly drawn to it. This was the same case back then, but I did think that it would be useful to have a better understanding of mental wellness or illness, as it often has an effect on the presentation in various other disciplines, because we are all, of course, humans with brains in various states of health. My psychiatry rotation was set at a geriatric center. It was a single low building on the campus of a much larger hospital complex. Most of my rotations were contained within that one campus, which in retrospect was very fortunate. As you may have guessed, the inpatients at the center were all senior citizens. Many of them were there for minor procedures, but because of their advanced age, required a little bit of extra care. And quite a few of them were there. They were essentially terminal, and they were kind of using the facility as a way station between the hospital proper and the hospice. The doctor I was shadowing at the time's name was Dr. Leopold Elric. Now, I remember his name because it was distinctively German, which played into the stereotype about Freudian psychiatrists. But when I met him, he had no accent, he had no knowledge of German culture, he was third or fourth generation American. But I do remember reading my brief the week prior to starting the rotation and imagining all kinds of horrible things, straitjackets, electroshock therapy, all this kind of one flew over the cuckoo's nest stuff, the tropes one associates with what is ultimately an unfairly vilified specialty. The only item out of those naive, stereotypical images I had in my head that actually manifested was the lack of things you could hurt yourself with in the rooms. No hangers, no shoelaces, nothing cord-like. Patients on the ward I was in had the standard hospital slippers and gowns that fastened in the back with a tiny hasp and button, no drawstrings. Those buttons were really hard to fasten, even for the staff, and most patients didn't even bother. They instead let their rear ends express silent protest at the indignity of not being allowed to have something as simple as a short length of string to preserve their modesty. Apart from that, it was a peaceful ward, certainly as peaceful as any other ward. There were cries in the night, there were combative patients, and there were all the usual conflicts, but nothing you didn't see to a generally greater degree in a typical hospital ward. Honestly, all in all, it was a nice respite from the cardiology rotation I had done previously, where every second counts, and everyone was pretty much yelling all the time out of either urgency, frustration, or grief. So, as is the point in such a rotation, Dr. Elric gave me a wide swath of patients to hit on my rounds while shadowing him. There were obviously patients he didn't want me doing anything with, the chronic or complicated cases that he'd invested too much time in personally to let me do much more than observe. But this was a teaching hospital, so there were patients where, at his discretion, I was able to perform procedures, make diagnoses, etc. One morning, Dr. Elric introduced me to a Miss Violet Adams. Miss Adams, Dr. Elric explained to me, was experiencing a seeming disconnect from herself, almost a Jekyll and Hyde type of personality split. And it happened in near perfect unison with the rising and setting of the sun. He wanted to know what I made of her case, so I examined her that morning, and then again that evening, and I witnessed the exact behavior he had indicated. She didn't recognize me when I came back in the evening and seemed much more agitated than she had in the morning. I told Dr. Elric that I thought she was clearly experiencing multiple personality disorder, what is now called dissociative identity disorder. He clucked his tongue at me as if I had disappointed him. He asked me to describe the similarities between the two personalities I had interviewed, and as I did so, aloud, I saw his point. Both Mrs. Adamses knew their gender, they knew their age, their name, they shared experiences and memories, with the notable exception of the memory of my examination. But apart from that last anomaly, these similarities more or less ruled out MPD, where most of the time the personalities identify as completely different people and completely different types of people. Miss Adams at night still seemed more or less like Miss Adams in the day, albeit she was much more aggressive, angry, and seemingly frustrated with everyone around her. Having little experience and having exhausted the only diagnosis that had occurred to me, Dr. Elric enlightened me, and he explained that what Miss Adams was experiencing was almost certainly diagnostic of Sundowners syndrome. And what that is a specific subset of symptoms that occur in people with mild to severe Alzheimer's or dementia. Miss Adams had a mappable set of behaviors according to the time of day. And by time of day, I mean the position of the sun in the sky, not any of our more arbitrary notions of time. Her behavior didn't fluctuate with the back and forths of daylight savings time. They didn't have any kind of dependence on the times that she ate at or anything like that. Any of the other cues that we sometimes associate with the passage of time. It was as simple as when the sun came up, she was pleasant, kind, almost ebullient, but her mood charted downwards on a slight slope until sundown, at which point it just plummeted to a nadir, where it remained crushed for the entire course of the night, which the nights were unpleasant for her. She experienced memory loss, she had bouts of anger, occasional seizures. Who said growing old isn't fun? I had never heard of Sundowner syndrome up until that point. And the mechanism for it is pretty inscrutable, apart from its symptoms. It has one thing going for it, in my opinion. It has a very evocative name. While I think naming diseases for their principal discoverers is laudable, and that little bow to vanity probably acts as an extra incentive, which, in the end, only helps the human effort by encouraging competition. I do think names like Sundowners are more useful to the public at large, and I wish we had more like it. We have comparatively few in medicine. We need more golfer's elbow, lockjaw, boxer's ear, names like that. Ankylosing spondylitis doesn't really do anyone any favors outside the medical community. Anyway, back to the topic at hand. Sundowners is thought to be linked to a chemical, a hormone, a neurotransmitter, an uptake inhibition, something along those lines, which syncs up with the body's circadian rhythms. But like I mentioned, while the symptoms are very well recognized, the mechanism for the cause is poorly understood. So Dr. Elrich asked me to continue observing Miss Adams over the course of the 4 weeks, which I did. I was curious if she would start to recognize me at any point, and I was surprised that she did start to recognize me immediately the next day, both in the morning and at night. It was almost like she needed to see me in each of her divergent mental states in order for me to be considered more than half a living creature by either one of them. So during those weeks, the thing that stood out to me most about Miss Adams was the extreme dichotomy her two mental states exhibited. There was no cruelty or guile at all in her during the day. It was very much as if she had broken her personality into two halves, and there was no mingling of the two in either state. And this caused me to be confused a bit with regard to multiple personality disorder. While I did agree with Dr. Elric that she was not classic MPD, there were just too many boxes that went unticked. I felt strongly that there must be a connection between what she was experiencing and the underlying pathology behind MPD. I made it part of my rounds to ask her each morning about the previous night, and each night about the previous morning. The component of memory lapses was hinted at when she initially did not recognize me until both her aspects had met me. But I was better able to pinpoint what was happening exactly after a few more visits. She seemed to have very good recall at night about the Jekyll version of herself, but the converse was not true. Her Jekyll could recall nothing that occurred the previous evening while she was manifesting her Hyde. Once I uncovered this fact, it opened up new avenues for conducting my own pet experiments, the contents of which aren't really germane to the current topic. Perhaps I will discuss them at some future time, but if and when I do, they surely will warrant their own vlog entries. So what was the root cause of the difference in disposition between the two Miss Adamses? If I could tell you that, I'd be a famous man, especially since the disorder would probably lose its current colorful name and be replaced with my own rather bland surname of Prince. But as I mentioned in my opening, I have my beliefs. There is so much that is not understood about the human mind, but there's no shortage of theories floating about. One theory about anger in general surmises that it almost always stems from cases where the brain cannot reconcile reality with its own internal construct of what reality should be. We all know people that are slaves to habit, addiction, or even just routine, where any variance from that routine causes some mild level of agitation. So this is just an extreme offshoot of that tendency. Under this postulate, when the sun goes down, a chemical inhibits neurons from their optimal performance, and the resulting confusion causes a deep rift within the brain itself. It's really a form of self-hate. The brain is angry at itself for not being able to make sense of its presented reality. The reaction is what manifests outbursts of anger, frustration, hate, all born of fear. The number of psychiatric theories about abnormal behavior that come down to a j'accuse moment levied at fear is really quite astounding. If correct, eliminating fear of the unknown would result in some remarkable cures for a myriad of mental illnesses, uncontrollable rage being primary among them. So that's all we need to do, is eliminate all fear. We'll all be better off. Sounds easy, don't you think? If there was a pill that promised to do it, would you take it?